Hello, my dear students. I'm Dr. Seethalakshmi from the Department of Oral Medicine and Radiology. I have an experience of for a decade as an academician. Today, we are going to see about examination of swelling. I think you would have dealt the same subject in your third year in general medicine and general surgery. But what difference? Here we are going to see pertaining to oral and perioral region. Come, let's get into the subject. Coming to examination of swelling. What is a swelling? A swelling is a very vague term which denotes either an enlargement or a protuberance from your body. It can be because of various reasons. So according to the type of reason, according to the cause, you can classify the same swelling into various categories. Like the swelling can be a congenital swelling, it can be a traumatic swelling, inflammatory swelling, neoplastic. These, or whatever I am giving, it is according to the cause. So according to the cause, you can categorize the swelling into various type of swellings. So coming to examination of swelling, examination of swelling starts from history taking. So a proper history gives you almost, you can be very close to the diagnosis. So a proper clear history is very much required for a good diagnosis. So where do I start with the history? Duration. When a patient comes to me and tell me that there is a swelling, doctor, I have a swelling. So what questions I'm going to ask them? I'm going to ask how long it is there. What is the duration of your swelling? Whether certain patient might say, doctor, yesterday night I was all right. Today morning I saw a big swelling. So that tells you that it is an acute swelling. Or certain patients will say, doctor is there for a very long time. It wasn't bothering me much, so I didn't come. Maybe now the size is a little more, so I thought I'll come. Why not? I'll come and have a checkup. So this tells me that it is there for a longer time. What inference I'm getting from it? If it is like a very short duration, it is an acute swelling. If it is there for a very longer period, then it is a chronic swelling. So with this question of duration, I'm able to come to a conclusion whether the swelling is an acute swelling or a chronic swelling. So then, since I asked how long it is there, I need to know what is a pattern of the swelling. It is not going to be the same. For certain type of swelling, it is going to be sudden, just like that. And certain swelling, it is going to be very slow. So the pattern, or it is called as mode of onset. It is very important for you to ask how it has started. So if it is a traumatic swelling, that is, if the patient has met with an accident, then he had a fracture of his mandible, then there is going to be a sudden huge swelling. So then I know that it is because of a fracture. It is an inflammatory swelling. Then it can be because of likewise, as I said before, it can be a very slow growing swelling. When it is a very slow growing swelling, then I have to think that it is a benign tumor or a benign swelling. Benign tumor is a very scary term, but benign means it is a very slow growing and subtle. It is not going to harm him much. And certain swelling will be slow for certain period of time and suddenly it can increase in size. That is an alarm. That means the swelling was chronic, long-standing, silent for a short period of time, and later on it has become painful. So that means that swelling, I have to be more cautious because I'm expecting some kind of sudden change, maybe a malignant transformation. The next question what I'm going to ask is it associated with pain? Generally, patient comes to you when there is pain. If the patient, very rarely, if it is a long-standing or if his appearance is going to be altered, then they might come to you. Otherwise, the main reason will be pain. So if the swelling is associated with pain, then it is an inflammatory condition. If it is not associated with pain, then it is a growth, a tumor. It can be benign or even malignant. When I am talking about pain, you have to ask certain extra questions of how exactly the pain is, the nature of the pain, whether the pain is a throbbing in nature. Throbbing, usually it is there in inflammatory swelling. And there is, patient might say it is very sharp and lancinating type of pain, then it is associated with some nerve. Whether the swelling is impulging or it is compressing the nerve, then you will have a lancinating type of pain. Then again, the site of pain is also very important. If it is a very localized swelling, it will be pertaining to that swelling site. If the swelling, if the pain is referred, then you can think whether whatever the swelling is compressing a nerve, so wherever the nerve is supplying, the pain is also getting radiated. So you have to ask whether this pain is localized or it is radiating. And then any other associated symptoms along with pain, like if the patient is the swelling is associated with fever, it gives us a lot of information. If a swelling is associated with fever, that means it is an infectious swelling. Maybe the patient has any bacterial or viral infection. For example, mumps. Mumps, you will have swelling in your parotid region. So that swelling will be bilateral and patient will have a history of fever. So if the patient is telling, doctor, I have fever for certain time and then the swelling is started, that means that is an infective swelling. Or patient might have some other associated symptoms like, doctor, I have difficulty in breathing or I am not able to swallow. That again is an alarming condition. That is, the swelling is big enough so that it is compressing the vital organs. So that has to be taken care immediately. Example, in case of cellulitis or in case of angioedema, any allergy condition, the swelling enlarges and it compresses your pharynx or larynx. So patient will have difficulty in swallowing and difficulty in breathing. Now this is about the history. Now coming to examination of swelling. Examination of swelling, having taken a proper history, would have led you to a kind of a diagnosis. Now adding on, we have to examine the patient. What are the steps in examination? You can start with inspection, palpation, percussion and auscultation. Generally, with inspection and palpation, you would have come to a very close to the diagnosis. If required, you will go with percussion and auscultation. So in inspection, first and foremost, on inspection, you look into the swelling, where exactly the swelling is present, the location of the swelling. And the location of swelling gives you a lot of diagnostic value. If the swelling is present in the line of fusion of the embryonic process, then it is a developmental swelling. Example, dermoid cyst. If the swelling is present in the mid-palatal region, then it can be a median palatal cyst. Or if the swelling is present in the junction of globulonasal process and the maxillary fissure, then that gives you a diagnosis. It can be globulomaxillary cyst. Am I going to give globulomaxillary cyst only with the location? No. Because I am going to see even the other characteristics. Is there any local factors which is going to pertaining to that swelling, or it is just the swelling but patient is not giving any other complaint. Then, so it is not a diagnostic, it doesn't give a direct diagnosis, but it adds on to your diagnosis. Then if the swelling is present within the jaw, then you will, the location on pertaining to location, there will be bicortical expansion. So those, if the patient, when you see there is bicortical expansion, then you know that the swelling is present or the swelling is coming from the center of the bone. So there will be expansion on both the sides. The next inspectory finding, what you have to see is the number of swelling, whether the swelling is a single swelling or multiple swelling. Mostly single swelling can be a soft tissue or inflammatory. Single swelling examples are cyst, abscesses, lipoma, fibroma, like that. Multiple swellings, the most common example for multiple swellings are neurofibromatosis. Just check for whether the swelling is solitary or multiple. The next is color of the swelling. Looking into the color, you can say what is the cause of the swelling. Red color swellings can be due to increased vascularity or pooling of blood. So those two swellings will give you a red hue. Black color swelling denotes that it is because of pigmentation. A very common example is melanoma or benign nevus, or sometimes even a necrotic swelling will have a black hue. Yellow color can be seen if there is adipose tissue beneath the swelling. So a classic example is lipoma, or sometimes the Fortis granites, it's not a swelling but still Fortis granites you can have a yellow color. That is because adipose tissue is there behind it. Bluish color can be because of congestion or tissue cyanosis. When there is congestion, you will have bluish color swelling. Examples are ranula, mucocele, where the swelling is big enough and it is congesting and it is compressing the blood supply. Then pink color as such, there is no pink color swelling. If the swelling is in the color of the surrounding mucosa, then you call it as a pink color swelling. A very common example is fibroma or neuroma, where you will have the similar color to the surrounding mucosa. Okay, so far we saw about the location, number, color of the swelling. Now we'll see the shape of the swelling. Shape is just to tell a clinician that how it is looking. So when you when you talk about shape, you have to denote it in a 3-dimensional way and not a 2-dimensional. So your shape can be either, shape of the swelling can be either ovoid, pear, spherical, or it can be irregular. The next is size of the swelling. Size is for recording purpose. So you have to measure what is the size of the swelling, and you can represent it either in centimeters or millimeters. But for recording purpose, you have to mention the size of the swelling. Then you have to look into the surface of the swelling, the surface which is covering the swelling. The surface of the swelling can be smooth or irregular or corrugated. When I will see a smooth swelling, if the swelling is arising from the connective tissue, the superficial epithelium is not affected, then I will see a very smooth swelling. If the epithelium is involved, then I will see a corrugated or a cauliflower-like swelling. For example, all benign connective tissue tumors will have a smooth surface, and all epithelial tumors will have a corrugated surface. Next is margins of the swelling, whether the margin is well defined or ill defined. So well defined margin is there for benign tumors. A benign growth will have a well defined margin. Ill defined margin, usually it is present for the inflammatory swelling. So inflammatory swelling, it is a very superficial swelling, so you will not be able to find where exactly it starts. So you will have a very ill defined margins. Then you have to see the skin over the swelling, how the skin is appearing over the swelling. The surface, either you can, it is very similar to, ma'am, you just said surface of the swelling and now you are saying skin over the swelling. Surface of the swelling generally for intraoral swelling I was talking about. But here in case of extraoral swelling, we have to look into the skin or the mucosa over the swelling, how it is appearing. So there can be edematous, the skin can be red and edematous in case of inflammatory swelling, or it can be stretched and shiny. So when it is stretched and shiny, generally any rapidly growing swelling will have this stretched and shiny appearance. So that gives you that has to ring a bell in your mind that the swelling is growing very fast. Then the other type of skin conditions you can see is, you can see a black punctum on the surface of the swelling or surface of the skin. The black punctum tells you that it can be a sebaceous cyst. So you have to look into the skin over the swelling. So these are the inspectory findings, what we saw. Then you have to go for the palpation. So with inspectory finding, you know where exactly the swelling is present, what is the color. So color denotes you what can be the cause of the swelling and how the surface is there, what is the chronicity of the swelling. If the surface is not very tense, then it is a chronic swelling. If the surface is going to be more tense, then it is an acute swelling. Okay, so these are about the inspectory findings. Then we'll go to the palpatory finding. Palpatory finding, first and foremost, what you have to do is check for the temperature. Ma'am, generally we usually see the side shape and then only temperature. But temperature has to be checked first, because when you try to manipulate the swelling on palpation, the surface temperature rises. So before any manipulation, try to check the temperature. How do I check the temperature? Intraorally, you cannot check the temperature. Only for extraoral swelling, you can go for checking the temperature. I have to use the dorsal aspect of my hand. So dorsal aspect of the hand, when I'm going to place over the swelling, I can feel the rise in temperature. How do I know that there is rise in temperature? I compare it with the normal side. Okay, if I'm going to have a rise in temperature, I'll compare it with the normal side, whichever I consider normal side. Generally, it's the opposite side. Then I can find that there is rise in temperature. Generally, there will be rise in temperature when the vascularity is increased, that is inflammatory swelling, any infectious swelling, and where any vascular malformation swelling will have a raise in temperature. Then tenderness to palpation. What is tenderness? The term tenderness can be given when you apply pressure and then the patient elicit pain, that is tenderness. If the patient is complaining by himself, then it is called as pain. So that is the difference between tenderness and pain. So now we have to elicit tenderness, whether we have to check whether the swelling is tender or not. Generally on palpation, if the swelling is tender, then it is an inflammatory swelling or an allergic swelling, infectious swelling. If there is no tenderness, that means that it is there for a longer time. So there is no tenderness. So mostly it will be a benign swelling, or even a cystic swelling can be non-tender. The next one is again size, shape and extent. This we have already done in our inspectory finding. Now what we are going to do is we are going to confirm it on palpation. In inspection, I have seen a particular size, but on palpation, it might change. For certain swelling, it might not change also. So that I have to confirm. I have to confirm the size, shape and extent on palpation, and if it is different, I have to record it. If it is the same, then I will write all the inspectory findings of size and shape are confirmed on palpation. Then you have to look for the edge or the margin of the swelling. What am I going to look at the edge or the margin is whether it is well defined or ill defined. Well defined margin will be there for any benign tumors. Benign swellings or growth will have a well defined margins. Ill-defined margins will be there for any inflammatory swellings. All inflammation, it is going to be there. It's an acute inflammation. It goes to the spaces of the skin. So there you will have a very ill-defined margins. When I am checking the margins, I have to check one particular, there is one particular sign called as slip sign. So when I am going to check the margin of the swelling, I am going to apply pressure to one side of the swelling. When I am applying pressure to one side of the swelling, if the swelling slips away from my finger, that means that the swelling is well encapsulated. A very common example of slip sign, positive slip sign is lipoma. In case of cystic swelling, if I am going to apply the same pressure on the margins, it is going to yield, that is, it is going to bend slightly. So that tells me that this is a cystic swelling. Then on palpation, you have to check for the consistency. Consistency of the swelling can be from, there can be various consistencies, starting from it can be soft, hard, firm, rubbery, everything gives you an idea. If the swelling is soft in consistency, then it is because of a cystic swelling will be soft in consistency, a vascular swelling will be soft in consistency because these contains fluid, these contains vascular blood or fluid. So it will be soft in consistency. Similarly, inflammatory hyperplasia, inflammatory swelling also is going to be soft in consistency. Rubbery in consistency, if the tissue is firm and rubbery in consistency, it is a very common in, it is seen very common in lymphoma or any kind of benign swellings. Then firm in consistency, all connective tissue swellings will have a firm in consistency kind of swelling, and carcinomatous swelling will be firm sometimes. Bony hard consistency can be there. Bony hard consistency, if the lesion is arising from the bone, it is going to be bony hard. Any bone lesions will have a bony hard consistency. Example, osteoma, exostosis, osteosarcoma or chondroma will have a bony hard in consistency. So speaking about consistency, lymph node swelling will also be present as, patient will be representing as swelling. So lymph node alone has various consistencies and each consistency will give you a diagnosis. So if the lymph node is firm and rubbery, that denotes that it can be a lymphoma. Lymph nodes can be soft if it is infectious. It is firm and shorty. Shorty meaning it is very small and it is slipping away. So it is a very classic feature of syphilis and any viral infections. Lymph nodes can be matted in the sense if there are two swellings and they are just joined here and there, then that is called as matted. So if you are able to find a matted kind of consistency, then it denotes it is a tuberculous lymph node. lymphadenopathy. And if the swelling or if the lymph node is going to be rock hard, then that is a metastatic. That is, it is showing a big alarm that it is a metastatic lymph node enlargement. The next point you have to see is fluctuation. Generally, fluctuation is done in general medicine. Very common thing what you have seen in your general medicine is ascites, where the doctor keeps one hand in the belly and taps from the other hand, and you will be able to feel the movement of the fluid. So, fluctuation is just to check the movement of the fluid if it is a fluid filled cavity. So, where exactly for intraorally it is very difficult to use your entire hand because the swelling is going to be small, right? So here we use fingers. I place 2 fingers to fix the swelling, and with another hand I will tap from the other hand, the finger from the other hand. So when I'm tapping, I'll be able to feel the movement of the fluid. This is for fluctuation if the swelling is slightly larger in size. If it is going to be very small, where I'm not able to place 2 fingers, it is going to be very small swelling. Then what I do is, I just place my hand on top of the swelling, the finger on top of the swelling and try to move down. So if it is going to yielding, it is a fluid fill. Sometimes I can give a false positive. It can be example a lipoma or myxoma where there is no fluid but still it might yield. So just a finding which we have to correlate with the other findings for us to come to a diagnosis. Then checking for the translucency. Translucency, again we check if the swelling is filled with clear fluid, that is either water or a serum. If there is clear fluid, the swelling will be translucent positive. So how do I do it? I place the torch in one part of the one side of the swelling and check whether I am able to the light is transmitted to the other side. It will be positive only in case of a clear fluid filled swelling. The next is you have to check for the reducibility and compressibility. Reducibility and compressibility both almost sound similar, right? But there is a lot of difference. Reducibility is if I am going to apply pressure over the swelling completely subsides, but it doesn't regain to its original position. It needs a slight push from the other end for it to regain its original size. But compressibility is if I am able to put pressure on the swelling subsides, but when I release the pressure, it gains back. What is the example? Reducibility, meningocele or lympharix, or very commonly inguinal hernia in general medicine, where if the doctor is going to give pressure, it will go into the internal organs, and if the patient is going to give an internal pressure like coughing, the swelling comes again. For example, for compressibility is hemangioma or any AV malformation, where if I am going to apply pressure, the blood goes through the vessel and stays there, but when I am going to release the pressure, it pulls back to the position. So that is compressibility. So you have to mention whether the swelling is reducible or compressible. That gives a lot of idea for the diagnosis. Then you have to check for pulsation. Where exactly I have positive pulsation. Positive pulsation can be there in case of if the swelling is present over an artery. So in either it can be, the swelling can be within the artery or it can be present above the artery. So if I am going to place a finger over, if the swelling is present above the artery and if I am going to place a finger over it, I will be able to see the upward and outward pulsation. If it is a expansile pulsation, the pulsation again it can be either transmitted pulsation or an expansile pulsation. Transmitted pulsation if the swelling is present above the artery, and expansile meaning it is present within, so it is expanding altogether. Now the next one is fixity of the overlying skin or the mucosa, whether the skin is movable, or the very easy term is pinchability of the swelling, whether the swelling, the skin over the swelling is pinchable or not. If the skin over the swelling is pinchable, that means it is present far beneath the skin. If this skin is not pinchable, that it means that it is an inflammatory swelling. It is involving even the skin. So that gives you a diagnosis whether the skin is pinchable or not. Then relation, how far the relation to the surrounding structures, whether the swelling is movable, whether the swelling is fixed to the underlying structure or it is fixed to the above structure, that is the skin, everything. What is the relation it is having, general relation it is having with the surrounding structures. Whether generally we do this for tumor, benign or malignant tumor. Benign tumor will be movable, it is not fixed to the underlying structure, but malignant tumor, it is fixed to the underlying structure, and if it is fixed to the underlying structure, it is called as induration. This is about inspection and palpation. Percussion on auscultation, generally it is done in general medicine for a bigger swellings, but we usually don't go for percussion and auscultation here in dentistry. But in case if we want to tap or if we think that it is a fluid filled cavity, maybe you can go for percussion, and if it is a vascular swelling, you can go for an auscultation to hear the bruit. Now that's about examination of swelling. We'll just go a small overall go through of what has happened in this lecture. You start, if the patient complains of a swelling, where do I start? With the history. In history, I ask how it is, what is the duration, how long it is there, is it associated with pain or any other symptoms. And then I go for inspection. In inspection, I see for site, size, shape, extent, number, then surface of the swelling, skin over the swelling. These are the things I check in the inspection. Then I go for palpation. In palpation, I check for temperature, tenderness, and then I confirm the site, size, shape and extent, and then margins of the swelling, how the consistency of the swelling, fluctuation, whether the swelling is translucent, and compressibility and reducibility, and also check for the pulsation, whether the swelling is associated with any arteries, it is close to the arteries, pulsation and the skin overlying the swelling. That's about palpation. And then if required, we'll go for percussion or auscultation. That's about today's class. If you have any queries, you can contact me through email. I'll meet you with another interesting topic. Thank you very much.